Good afternoon, everybody, and welcome to Advancing Minds, Insights into Mental Health Research. I'm really glad you could join us all today. My name is David McGrath. I'm the Director of National Mental Health Strategy for Ramsay Healthcare, and I'll be chairing the session this afternoon. I'd like to begin by acknowledging the traditional custodians of country throughout Australia and their connections to land, sea and community. I pay my respects to their elders past and present and emerging, and extend that respect to all Aboriginal and Torres Strait Islander peoples joining us today. I'd like you to note that this session will be recorded. We'll have an opportunity to hear from our panellists, who I'll introduce shortly. And then at the end of the conversation with our panellists, we'll have a brief period of time for discussion and questions. There is a Q&A function at the bottom of your screen. If you'd like to ask any questions throughout the course of the conversation, please feel free to add those questions into that function, and we'll get to those that we can by the end of the conversation. I'd like to now briefly introduce our three speakers who will be taking us through the landscape of mental health research. Firstly, to welcome Professor Mal Hopwood, who is currently the Ramsay Healthcare Professor of Psychiatry at the University of Melbourne. He's based at Ramsay Clinic Albert Road. He provides inpatient care within the professional psychiatry unit, as well as outpatient consultations focused on second psychiatric opinions. Welcome, Mal. Thanks for joining us today.
Thank you, David.
Our second speaker is Professor Jane Fisher, who's an academic, clinical and health psychologist with long-standing interest in the social determinants of health and healthcare participation. Her research has focused on gender-based risks to mental health and psychological functioning from adolescence to midlife, in particular related to fertility, conception and pregnancy. And welcome, Professor Jane Fisher. Thanks for joining us today.
Thank you for having me.
Great. And our third speaker is Dr. Clara Massaneda-Tenu. He's a consultant psychiatrist from Spain who is currently completing a PhD at UNSW and working as a study psychiatrist in clinical trials at Ramsay Clinic Northside. And thanks for joining us, Clara.
Thank you, David.
Okay. So look, the format for today is I'm going to ask our panellists a number of questions, particularly on areas of mental health research, and draw out from that particular areas of interest that might be pertinent to all of you that are listening. And as I said, at the end of the conversation, we'll have an opportunity to go over any questions that you might have. I might come to you first, Mal, and just ask, what are some of the key areas of focus and recent developments in mental health research from your perspective?
Well, I think one of the things that's shifted over the last few decades, David, is a recognition we need to do mental health research at multiple levels. Mm-hmm. The community, at a social and psychological level, and then more towards the end where I tend to sit at, with people who are most unwell and in hospital, where we're often looking at new biological treatments. I think the other big shift we've seen over the last 20 years that will be familiar to most people is the rise of research into early intervention. Mm. with the tantalising prospect that we can prevent mental health disorders developing. Sadly, at this point, we know we're not perfect at treating them, and many of them have a nasty habit of being recurrent. If we could prevent it, really would be revolutionary, to say the very least.
So looking at the trajectory of illness and being able to tie together research along that trajectory is important.
Yeah, very much so. And it's an important notion because historically mental health research has often focused on the cross-sectional, particularly treatment research. Whereas for many people, we're talking about problems that start relatively early in life and recur or even remain throughout their adult life. And really, the more we can do to stop them getting there in the first place would be a very good thing.
Yeah, thank you. No, I certainly think there's a degree of truth in that, and particularly the history of research being so compartmentalised is a challenge for all of us, and being able to overcome that's important. Jane, I might just move on to you with that sort of thought process. Given your history of research, what's your thinking on that connectivity across the determinants of mental health?
Look, I think Mal has captured it very well, that we need to think of this layered approach to understanding the origins of problems, when we can intervene most helpfully. And that goes right across from mental health promotion, health education, to understanding the best ways of treating problems. The thing that I would add is I think there's great benefit in trying to focus on preventing intergenerational transfer. And that's why I have a particular interest in early parenting services, where we can perhaps help parents who have difficulties, often with the more common mental health problems, highly anxious or low mood, enable them to care for their babies and young children with more confidence, more parenting efficacy. So perhaps those children are set off on a better trajectory.
There's a really strong growing band of evidence now about the importance of the early years of life, isn't there, in mental health trajectories?
Absolutely. And that if you can get, especially in those 0 to 5 or 0 to 8, you can get things really onto a strong footing, the social and emotional development of young children, their capacity to relate well, that those are foundational skills for the future.
And builds the whole community's strength in the long run.
It does. Yeah.
Clara, I might seek your views on that thought process around the sort of key areas of focus and recent developments in mental health research from your point of view.
Well, I completely agree with Jane and Malcolm. And I think I agree that there's a growing emphasis on early intervention and prevention strategies for mental health disorders, particularly in children and adolescents. And maybe I would add that for me, one of the most significant recent developments in mental health have been the research related to psychedelics-assisted psychotherapy, because I think it's been a while since we had such promising results in a novel treatment target with so many possibilities ahead, which is also giving, I think, a lot of hope to patients and people. So yeah, that would be my response.
Yeah, it's a real paradigm shift, isn't it? That opportunity to look at, a really different set of medications and the impact on people's illness experience. That's a major paradigm shift.
Yeah, absolutely. I think that at least from psychiatry perspective, we haven't had any new treatment medication with such promising results. And also we are kind of emerging psychotherapy and pharmacologic perspective for the first time, and we are actually seeing how good it is. Yeah. And so I think that this has been, from my perspective, a great recent development in mental health research.
Yeah. That link between the various skill sets of the professional disciplines and being able to bring those in a collaborative way to deliver on outcomes for people in the mental health space is clearly the way of the future.
Yeah, exactly.
Okay, great. So, and I might just come to you, Jane. In terms of recent research, are there major paradigm shifts from your point of view that you think are worthy of note?
Well, Well, look, I think this appreciation, as the others have agreed with, that the early years of life are of fundamental importance. But if you're seeking to influence those, you have to influence the skills, sensitivities, capabilities of their parents. And often their parents' own skills have been shaped in less than ideal circumstances. So I think we are understanding better the impact of what get called adverse childhood experiences on mental health, both the common and more severe mental health problems, but also on this capacity to care well for children. And these are big problems, they're hard to prevent, but I really agree with Mal that we need to put a lot of effort on assisting people who've had childhood adversity or other forms of trauma through their lives to manage their caregiving in the best way they can. So I'm a big advocate of parenting education, and also what are being experimented with, which is community hubs, where a family that might have high needs of all sorts of kinds, legal, health, mental health, can go to one place to get assistance in overcoming some of these problems and making intergenerational change. So I think it's a promising way forward.
So the policy and service delivery environment is starting to move along with the research, but do you think it's keeping up with the research?
Look, it's a good question. The research in these kind of complex systems is quite difficult to do, identifying what the outcomes are. And also the intervention needs to be in place for quite a long time to see if it's had an impact. If I could just talk briefly about the program that Ramsay has supported us to do. So Ramsay has a number of early parenting services in its suite of services that it offers. And the one I work in at Masada Hospital in Melbourne, we've been supported to follow a cohort of 1,200 women and their babies who were admitted to the service, and we followed them from pre-admission to pre-discharge to follow-up. And although cohort data is not perfect, because maybe this change just happened with the passage of time, it's very powerful evidence that for most people, this is a powerful, helpful intervention. So a brief, intense psychoeducational approach that really teaches them how to care better for their babies, and their babies respond. We have identified in that research, really for the first time, that the group of people who tend not to be able to benefit much from that program are people who have traits of borderline personality disorder. I know it's a contested label, but people who have difficulty with trust, difficulty with emotion regulation, difficulty with judgment. We're learning that that 5-night program is not enough. So I think it is going to provide us, collectively here, this kind of group with, well, what should we offer to that group of people who have, significant disability related to their symptoms.
So it speaks to teasing out the needs of various subgroups and being able to provide tailored types of care that are really focused around their particular needs.
And I think stepped approaches. So it was not that it was no value, it was just not enough. And that this plus something more might be better.
Absolutely. Thanks for that, Jane. Mel, what would you say might be the significant paradigm shifts that have emerged from research over the last few years?
I think, first of all, your question about service design-based research is a really interesting one. The community is really asking us for better services. Quite interesting that historically we were quite inhibited by a fear in mental health research that we'd do anything that would show a negative result and people would lose hope. But with the rise of, let's call it the lived experience movement within mental health, they're saying to us, well, your current treatments and systems are not perfect. Please work harder. And I think that's a terrific thing, personally. The shift that's leading to, in my area, particularly in the mood disorders and their treatment, there's two things in particular. One is a desire for better research to guide what's going to be the right treatment pathway for this individual. Arguably, particularly with medications, and even to a certain degree with therapy, we've not been very good at predicting what will be the best for you. Within biological therapy, one of the areas of great promise is so-called pharmacogenomics, where we look at individual variation in liver enzymes that metabolize most of our psychotropic drugs, or the enzymes that transport the drug across the blood-brain barrier into the brain. There's probably about a dozen steps within your body when you handle a drug, from into your mouth, if I can put it crudely, to your brain, that determine whether it works for you. We've only just started testing these, and we were fortunate at Albert Road getting a large grant from the foundation to use a pharmacogenomic test that looked at liver and blood-brain variations to predict antidepressant response in people with unipolar or bipolar disorder. We've recruited about 200 folk for that now. We'll monitor their response to selected treatment by their psychiatrist. So a real-world study, does this test add anything? And so there's real hope there. I think patients, as Clara hinted to earlier, are also looking at new treatments for disorders like depression, because our existing antidepressants that manipulate noradrenaline, serotonin, and to a lesser degree dopamine, we've probably gone about as far as we can go there, and have struggled to get a lot beyond a 40% remission rate, which really should be our target. Now, some of that's about the heterogeneity of depression. So again, through the foundation, we've been fortunate in having support together with industry partners to look at new treatments. We've got a number around the psychedelics. I think it's also worth mentioning ketamine and esketamine, which have been great interest to the community. They both bring all the fascination of bringing a drug that's previously been a substance of abuse treatment with all the complications involved. But we were fortunate to lead an Australia-wide study looking at quality of life improvement with patients with difficult to treat depression treated with esketamine, and we've treated about 60 at this site now. And that showed some really great improvements in quality of life in people who'd failed on average about 8 or 9 treatments. So, you know, it's pretty tough going for a person at that stage, isn't it? It's pretty hard to keep hope going. I don't wish to suggest that that's the last word on treatment, but a useful addition. And because people out there are quite desperate, I think it's really quite important to do this kind of research so we don't fall victim to overhype and over-expectation. So one of my jobs in recruiting people for the esketamine trial was to let them know this isn't going to work for everyone, because they'd read about it on that thing called the internet. We're absolutely certain they were going to be one of the ones that was going to help because TikTok said so.
Yes.
And letting them know, well, actually, the science may not support that is actually a very important role.
Yeah, absolutely. Look, I must say that's quite exciting, Mal, because obviously the variability in outcomes from mental health treatments is well documented compared to other specialties. And so the thought that we may be getting more precise at the individual level and also having a broader range of treatment options really is an exciting step forward and something to be trumpeting to the masses. Gareth, if I could just ask, Mal's raised a couple of issues, though, in what he's just had to say with regards to those particular treatments, particularly with some of the more novel treatments. Obviously, data privacy and ethics are crucial considerations in mental health research when dealing with sensitive information. How do you navigate those sensitivities in the research environment?
So, first of all research protocols are carefully reviewed by a designated ethics committee. In the case of our research, a human research ethics committee, alongside a scientific committee, to ensure that this study will be conducted in an ethical manner. This includes assessing and ensuring that data collection, management, and storage and like complied with local governance and legal regulations, as well as privacy of the participants, like to ensure that privacy of the participants are always protected. For example, data is always collected in a de-identified manner. So when a patient is enrolled in a study, participants are allocated a participant code or ID, which identifies their data, but doesn't contain any personal information. Also, there are systems in place to make sure that personal information is restricted and only accessible by authorized researchers. For example, when I extract clinical information from patient's clinical file, I save it onto research files and we place them in locked cupboards, only accessible by the research team. And lastly, but also like most important, I think that it's very important to say that participants are always aware of everything we do during the research study, and they consent all the steps that involve their participation. So before enrolling a participant in a study, patients are always given the opportunity to read an information package about the study. We always try to allow some time for them to speak with a clinician, ask any questions, express any kind of concerns, and they are always given a fair amount of time to consider their participation. And after that, they are invited to sign the consent form, and they are always welcome to withdraw. So this would be some of the, I'd say, some of the steps that in research we try to put in place in order to preserve these ethical concerns while advancing in our studies.
Yeah, so there's a lot of rigor that surrounds the approach. And I wonder though, so how do you handle the situation, say, particularly when we're talking about some of these new novel treatments? How do you handle a situation where you begin to observe a profound effect in the study during the study period? How do you handle that in terms of the needs of the participants in the study on both sides of the study equation?
What do you really mean?
Oh, well, so presumably you have people who are on the active treatment and people who are not on the active treatment. And say you see a profound effect from the active treatment. How do you manage that for the people who aren't on the active treatment?
Well, if the first thing is to consider if the person who's not receiving the active treatment, is there any detrimental effect on their health? And sometimes if this is really obvious, sometimes what we would do is to have a meeting with all the research team and consider whether like just go on or if we're gonna reduce the time of the research or if we should, like reformulate something. What we do also as well, like right now we're doing a clinical trial in ECT at Ramsey. And what we do is we ask the patients before and after the treatment if they think they know what kind of treatment they're receiving.
Right.
And also we also ask that exact same question to the clinicians and the raters, because if it's very obvious, then the blinding is not well preserved. So we try to monitor that because in a clinical trial, the blinding is really important.
Absolutely.
So that is a way to monitor it, I guess. And if it's like really obvious, then maybe we should, I don't know. We haven't found us in this situation yet.
Sure.
Hopefully we don't find ourselves. But yeah, this is a good way, I think, like to monitor it.
Yeah, makes tremendous sense. Jane, I imagine when you're dealing with parents and children that ethics is a significant component of your thought process. How do you manage ethics in your research environment?
Well, in the study that we've just completed, we were encouraged, and this was after careful discussion, to actually position it as a quality assurance activity.
Right.
And with help from Ramsey, who've been introducing a thing called Vision Tree Optimal Care, which is like an electronic medical record, we could make sure that all our pre-admission protocols, the data that were collected during admission routinely, and that these could be put onto the electronic medical record. Now, this made it more straightforward for patients. But the flaw in much prior research in early parenting services is that they have low recruitment and low retention fractions.
Right.
So you can't really tell, is there a big bias here that people who liked the program reported the impact more favourably than others.
Yep.
So we extracted data in an anonymised form from everyone's medical record who was admitted during this period. And then we were able to analyse it much more completely and comprehensively than has been possible before. Everyone who's admitted to the hospital is asked to tick a form saying, are you willing for your data to be included in quality assurance research? And anyone who didn't tick that, we couldn't use their data. But everyone who did tick it, the ethics committee regarded that as consent for anonymised data to be extracted for this purpose. And I would say that this has enabled us to do a much more comprehensive and thorough investigation than was possible before. So that was the approach that we took. And I think in an inpatient setting where there's a high turnover of patients, we admitted 1,200 patients in a year, that this has enabled us to do something that's not been done before.
It's a novel solution to a very tricky problem, and it sounds like it's reaped rewards at the end of the process.
I think it really has revealed things that were not known before we did this.
No, fascinating. Mel, can I turn to a question that's close to my own heart, which is research findings don't always immediately translate into real-world outcomes. What do you think are the barriers that stop translation of research insights into practical outcomes?
It's a very good question. I think one of the barriers is the limits of any one trial in any area, that we need as researchers to always be sufficiently humble about the meaning of our results. We've all seen the headline, "Cure for Alzheimer's identified," that says a rat got smarter given something that may or may not make the translation to humans in about 15 years, and almost certainly won't. So as researchers, we need to say, well, we've done a trial of intervention A, it was better than what we currently do. We'd really like to see that replicated a few times in large numbers of people for us to know that's a reliable result. Depending upon the nature of the intervention, it's then, is there an educational challenge for people to get skilled at delivering that intervention? And there may be economic barriers. So for certain new treatments in mental health, and probably esketamine and the psychedelics fit into this, the cost to a patient is really quite prohibitive. It involves talking about amounts of money with a patient I've never talked about before, and I'll admit I feel quite uncomfortable, actually. I really wasn't meant to be a plastic surgeon, with due respect to all the people. It's a new experience for me. So is that a good or a right thing? It feels potentially iniquitous. I think it's very important as researchers, therefore, we're prepared to get our hands dirty and work together with partners like industry and regulators, and be prepared to lobby governments. It's not a place that many researchers, not everyone feels comfortable in that space. But mental health needs advocates, and working together with the lived experience community, that's how we're going to bring about real change in practice.
And to a certain extent, the research community brings a sense of objectivity in the minds of the broader community that perhaps other interests don't have. So there's a real opportunity there to convey a message that will be heard.
That's right. And part of our role is to help interpret the evidence for others, that there is quite a science of interpreting the evidence well. Many people feel they possess an honours degree in that. It's perhaps not as widespread as should be thought. And that's where instruments like guidelines have an important role in influencing practice as well.
Yeah, absolutely. Shane, I might bring that question along to your thoughts as well, because given the work you do is very multifactorial across government agencies, government policies, service delivery frameworks. What do you think are the primary barriers to being able to translate your work into real world outcomes?
Look, I think Mal has positioned this very well. It's rarely one door that you have to push. So to me, it's being willing to engage quite broadly with communities with lived experience, with policymakers, very definitely in the field I'm in, with health insurers, because they're the ones paying for these services. They want to know that their money is invested in a worthwhile way. I think it's beholden on all of us to try and generate economic evidence alongside clinical evidence. The one group that I'd like to add is engagement with public discussion through the media. And, I know, and I think there is a question about misinformation, disinformation. Be interesting to talk about that. But look, I have an extraordinary privilege. I have half an hour on ABC radio every week with a drive time journalist called Raf Epstein. And we try and respond to questions raised by the listenership, often to do with psychological well-being, relationships, mental health, research evidence. And in being willing to engage with that talk back, I reach far more people than will ever read a paper I publish or anything I say. So I think being willing to engage with the print and broadcast media, with writing for academic readership through things like The Conversation, we do have a capacity to amplify our messages and bring them to broader groups. And then the last thing I'd like to say on this is politicians, that they have to advance a policy agenda that is politically popular. It behooves us to see, well, what's in it for you? What is your priority? How can we make this a win-win situation? We can provide you with something that's helpful for your agenda, perhaps in exchange for some better recognition of what it is that we're doing.
Yeah, and certainly if you can bring the community along with you on a given issue, you've done half the battle for the political class, which is very important. Yeah. Clara, I might offer the same question to you, given particularly in the sense of being able to take new clinical interventions and bring them out into a system that's immensely complex in this country. What do you think are the barriers to doing that?
Well, I'm not sure if I'm gonna add anything different from what my colleagues just said, because I think that it was like a really good explanation. I would just like maybe highlight that it's kind of complex to have to use the same kind of population that we find in real world clinic. Like to study it in research, because when you conduct a research, you really need to look at certain participants with certain diagnoses. We have a lot of exclusion criteria, and even though this is like how we try to do research so we can ensure the validity of the research, this is not what we find in real world clinic practice, right? And also sometimes, like for instance, in ECT, they say that in order to see if the patient doesn't have any kind of cognitive side effect, you need to, assess the autobiographical memory. But to do that, you need to assess like a really long survey that takes 30 minutes. This is possible in research, but it's not possible in the clinics because we don't have enough time. So sometimes what I'm trying to say here is that sometimes there are some factors in real world interventions that cannot be accounted for in the research project. And on the other hand, other factors that ensure the validity of the research project that cannot be done in real world intervention. So so I think that it's really important what Jane was saying before, is that someone that really understands the research and the clinical practice to disseminate, to divulgate, like to talk about what these results really mean and how this can be applied in the real world. Because I've been like, some patients, they've been asking me like, ketamine is great. Can I have it? You know, I've seen that amazing results, and they don't have major depression. They probably have like borderline personality disorder, and you know, so I think that is really, and they're just gonna read the main headlines. So I think that is really important, the work that some clinicians and researchers are doing through media to actually explain what this really means and to carefully highlight why this is going to be implemented, how is it going to be implemented, and for who.
I imagine one of the, like, you make reference obviously to the opportunity at the start to gather information on the individual. And what strikes me as one of the major challenges in getting research applied appropriately is treatment matching for patients. Being, as you say, being able to determine if a given patient should be matched to the right treatment, given our system is often very time pressured, and people are often making clinical decisions in half or a quarter of the period of time you might have in a research protocol.
Absolutely. And how many times do we find patients that they do not only have treatment-resistant depression, they have a lot of other comorbidities, or, you know, so yeah.
Yeah, no, understood. I might then peel off on another theme with you then, because obviously in being able to attract people into mental health research, stigma is a big issue, and across the whole mental health field, stigma is a big issue. What role can you see research playing in being able to reduce stigma in the mental health field, and particularly by doing so, being able to encourage people into research practice?
Yeah, I think that I think it's true that the stigma surrounding mental health sometimes leads people to be less willing to participate in research compared to other areas of a study. I remember I used to work right next to my colleague who's also a researcher, and he was doing research in oncology. And he had no problems recruiting patient participants. And I always struggled. And we didn't compete, but we were like, how many participants do you have? And he was like nonstop. And I'm like, oh gosh, this is so difficult. So yes, it has like a big role. It plays a big role. However, I believe that this dynamic is changing recently. And maybe Jane and Malcolm, like, feel free to intervene. But I have the impression that during the last maybe 5 years, and particularly, especially after COVID, there has been more open conversation about mental health, which I think that helps reduce stigma. And also, since research has begun on such innovative and promising treatments, I believe that more and more participants are open to participating, because I think that there's a new sense of hope in mental health research.
Yeah, no, I think that's true. I think there's certainly, when we're able to demonstrate new treatment outcomes that may have much better benefits than some of our historical treatments, that does generate hope and bring people along. Jane, can I ask, just along that line though, a couple of times in this conversation we've talked about borderline personality disorder. Would it be true to say that there are some diagnostic categories that probably are more stigmatized than others?
Well, I think that's a great example you pick, and that is a highly stigmatized label to apply to someone. I'm interested that the field, I think, has moved enormously in actually giving people information about the diagnostic labels that have been applied to them. When I was first training a long time ago, a person with schizophrenia was never told that's what the clinicians think you have. Whereas now I think that's normal practice to give people their diagnostic labels, to educate them about what it means. And I see that as a great advance in improving the mental health literacy of people experiencing their conditions and their families and communities. Borderline personality disorder might be the last one of these.
Right.
There's a bit of debate about whether it should even be called that. There's certainly a big argument that it should be called complex trauma disorder. And there's no doubt that people with these symptoms have a higher prevalence of histories of traumatic events, but they don't all have that. And so I think it is an area that really warrants our careful attention and probably really would benefit from detailed engagement with people with lived experience about, is this a helpful or not a helpful label to have applied to you? My colleague Anne Sved-Williams, a psychiatrist in Adelaide, has advocated strongly that if a woman caring for a baby has this, you should tell her. And she reads out the DSM-4 criteria and says, is this applying to you? And she says they find it really helpful. Now, that's in the hands of a very experienced psychiatrist and a team. So I think that's quite different than a self-diagnostic thing. But I do think this whole arena of discussion with people about the labels being applied to them is one of the steps towards reducing stigma, improving understanding. And I'd like to see it advance in this field.
I think we all would. I think that's it's an important component of being able to not just do research, but actually be able to encourage people into treatment for better outcomes.
I think so, and really to improve our practice to be able to get skilled at doing it. Yeah.
Mal, perhaps if I could carry that theme just a little bit further, because I have a question in the chat which I think is pertinent, and that's perhaps the impact of social media on mental health treatment and how the impact of that on patient behaviour, patient involvement, and self-prescribed treatment. What's your thoughts on the impact of social media, both in terms of stigma, but also in terms of bringing people in for treatment?
Well, perhaps if I include social media and internet-based information more broadly, I think it is important to say that overall they've been a good thing. So I see people approaching me now who are much better educated about diagnosis and treatment options and are better able to seek from me the information they want and the help they want. Yes. Now, that can be a bit challenging as a health professional. You're not used to that. I actually think it makes for a much better quality interaction in the long run. Yes, in the darker corridors of the internet and particularly in social media, is there an awful lot of misinformation around, which I'm sure is what the person was asking? Yeah, of course there is. We all know that. And, you know, it's interesting how that's created a fascination with some of the newer treatments. I want as the first thing I have. Or treatments with relatively little evidence. And quite one of the, I think, strongest cases is the use of medicinal cannabis to treat depression. The evidence supporting that is, I'll use a favourite phrase of mine, a very quick read, David. There really isn't any. That doesn't prove it doesn't help. The little bit of evidence we do have says you get temporary relief, and lots of people tell us that, but in the medium to long term, there may even be evidence that makes things worse. But we're seeing, driven by social media and changing access to prescribing doctors and on the phone, a shift in patient behaviour. And I think that's a real challenge to us. It's very tempting to say I think that's a bad thing, but that's not going to make it go away, just me saying that. I think we need to think about how we tackle that, and clearly there's a responsibility on us, you know, as academics and to whatever degree that's true thought leaders, to be making sure good information gets out there as well into these kind of channels. That's hard.
Yeah, absolutely. I mean, it sounds like social media can run ahead of the research evidence. And I guess research evidence is not particularly well constructed to be placed into a social media environment. Is that a fair statement?
Yeah, I think it is. And I think as an academic researcher, translating your detailed findings into 140 characters or less, a little bit like burning a Bible. It doesn't quite feel right. But I think we've got to get over that a bit, because that is the medium of discussion with the world. And, you know, in supporting Jane's earlier comments about engaging with the media, where many academics feel quite uncomfortable, I think we need to get over that. And I think that includes social media as well as the traditional media.
Yeah. No, thanks, Mel. I think there's a lot of truth in that. Clara, I've got a particular question that's been directed to you, which is, what's your thoughts on stigma, particularly with regards to ECT treatment, given a lot of the sort of, you know, popular media and the way it's portrayed in the popular media? Do you think it has a particular stigma?
Oh, yes, definitely. Definitely. I mean, Ramsey is like growing up a lot, like in regards of clinical trials. Like we are doing a clinical trials in ECT and now TMS, and we are also going to start a clinical trial in psilocybin. And all participants want to participate in all the clinical trials, but the ECT. Like I feel like what I'm trying to say here is that, yes, there is a big stigma, particularly driven by movies. There's a really famous movie that has damaged the image of ECT for years.
Yeah.
And it's such a shame, because it's a treatment that is really efficient and safe, sometimes even more safe than other treatments that we are giving. So it's to be honest, it's one of the work that we have to put in when we prescribed ECT as psychiatrists, to make sure that the patient understands what she's going to receive and how good this can be. But yeah, definitely it's a barrier to this good and really efficient treatment, especially for treatment-resistant depression, which, as Mal was saying before, these are patients that have been taking a lot of medications, tried a lot of different things, and which can be very discouraging. So yeah, it's a shame, to be honest. It's a real shame.
Yeah, it's tremendously challenging to find a way to overcome that view in the community, which, as you say, has been entrenched. I presume the movie you're talking about now is about 50 years old, so it's been well in the system and in people's mindsets.
Yeah, and for example, back in Spain, we tried to communicate what ECT was by giving like talk to general public. But then what you receive from people is like, yes, you're saying this because you are the psychiatrist, you're not the patient. And that is true. So what we try to do is we try to talk to patients that had received ECT, and we asked them, would you be willing to talk about your experience? Because I understand that if I say it, I didn't receive ECT, you know? Yeah. So it would be more reliable, and they don't want it because of the stigma.
Yeah.
So it's really challenging.
Yeah, it's a challenge for all of us to try to overcome in the period to come from here. Yeah, thanks, Clara. Jane, I've got a relatively complicated question, which I'm going to simplify a bit, which is about economics and the impact on research and mental health treatments that might impact on hospital stays and overnight stays, and the economic disincentives to do that for some of the service providers out there in the system. What's the sort of relationship you see between economics and research outcomes from your experience of mental health research?
Look, it's an excellent question, and I'd have to say that I think at the moment we probably can't answer it with confidence, which we should definitely be asking it. Is there a perverse incentive that says don't find non-hospital or community-based approaches because they will reduce hospital-based income?
Yep.
And I think that's something we have to be alert to. I think it also speaks to our need to continue to do the really well-designed trials that Mal was talking about, that we really have to be able to compare a hospital-based program with a community-based one. All the difficulties that Clara's identifying of how do you get a group of patients who are like enough to be randomly allocated to one or the other. But because they're such difficult trials to do, there are very few of them. And in this early parenting field, we tried to mount a randomized trial. And people in the community who you can see would benefit from it, they don't want just to be randomly told go to hospital or don't go to hospital unless they've formed that view themselves. But I think there is now enough collective sort of trial expertise in this area to begin to be able to ask that question scientifically and to answer it. So it's a very good question. Others might have a different view, but I don't think we can answer it quite yet.
Yeah, no, I agree. I don't think we have sufficient data to be able to look at the relationship between the economic outcomes and the research outcomes, but it's clearly that the future really is about being able to look at the best application of our resources across the system.
Absolutely, and the most efficient way of assisting people, so we don't foster dependencies, enable self-care, self-management to the greatest extent that we can.
Yeah, and thanks very much. And I hope I've done reasonable justice to your question, whoever that was online. Look, that brings us to the end of the time for our webinar today. I really appreciate all of you attending to hear what we've had to say. And I'd really like to thank our three panellists, Professor Mal Hopwood, Professor Jane Fisher and Dr. Clara Massanada-Tanu for their inputs. It's been a really interesting conversation, fascinating from my point of view, and I hope everybody else has enjoyed it. Thanks for joining us, and thanks for being a part of the Ramsay Hospital Research Foundation's Mental Health Insights event. Goodbye, everybody. Thank you.
Thank you.